We're recording. We're ready. We're starting. We have a new unit. Let's all get enthusiasm reigns supreme. And we're back finally here. So I don't have to walk across campus. Oh, good. Lord love it. All right, here we go. Are you ladies done? What, you didn't talk all weekend? Oh, I realize that I can't think of anything that's more important. However, an appropriate venue would not be right here. Why do I have to deal with this? It's all right. It's not easy putting up with me. I mean, I have someone I can put you in touch with who will tell you. I'm a little shook. It's a little bit crazy. Moving on. Here we go. So I normally sequentially I don't do this now. I wait and do how diseases spread. For the next unit, test wise, which obviously would be of interest to you down the road, for the third exam, we look at how diseases spread, how they kind of do their damage, epidemiological factors and terms, and then the focus point is this chapter. I'm starting it because, as per lab, we're supposed to be doing the lab this week. We're doing the antibiotic labs this week, and it comes up early in this particular PowerPoint. So I figured this would help you a little bit understand the background of what you're doing with both Dr. Dress and myself in lab this week. Okay, so that's kind of and it ties in nice because we just finished non-antibiotic methods of control. We had chemical and physical and mechanical. This is antimicrobials. So we use the term antimicrobials because it's more appropriate. And again, there's a lot of definitions in this. And you got to learn to use the right ones. I mean, they're not all antibiotics. Antibiotic is as you will see, is a very specific term. We have antivirals, antibacterials, antiparasitics, antifungals. They're all in this chapter, so there's a lot that's here. Our focus point is the antibacterials, and the subset, antibacterial is sort of the global one. Antibiotics is a very specific and major subset of that because the bio gives it away. It's got to come from other stuff that's living, naturally occurring. We just tinker with it in the lab. That's really where the jumping off point for this is. So, I mean, why they put these, I don't know. Gee, why do you think you would use it? To make money, right? That would be no. The idea from an altruistic standpoint is for treatment. The sources for the most commonly used ones, you're going to see the bacteria and the mold that we use. The testing is what's important. Okay, for vis-a-vis lab, you're going to see that early on. We're going to talk about things like therapeutic index and what really is important. The whole sort of the ball game revolves, if you will, around two words. Selective toxicity. Toxicity is easy. It's poison, damaging, killing, hurts. Selective means in some specific way. It doesn't apply to everything. And the whole idea of selective toxicity, everybody, is that it's going to be more harmful to the microbe than to the host. That's really an ball game. More harmful. I'm trying to print deeply. I may have you come up and write. No, I think it does. The micro, bad guy, whatever it is. Than, not then. Than the host. That's us. Voila. That's basically the ball game. And selective toxicity mirrors what's called therapeutic index. So the therapeutic index is effectively, there's two terms that mirror this. Therapeutic index involves, and we don't do this calculation, I do it for example up here. Therapeutic index is a ratio that compares the lethal dose, we call it lethal dose at 50%, or 50% time. In other words, the dose is likely to kill half of us. Okay? With the effective dose at the same percentile. So it's LD50 and ED50 one detect. But it's always got to be greater than 1. Okay? So it's got to be greater than 1, because you would never use something that's more likely to kill you than to help. So, for instance, if you have an antibiotic, whatever, any therapeutic agent, but for argument's sake, the antibiotic whose lethal dose is 100 milligrams, so put that LP, subset 50, and the effective dose was 10 milligrams, ED50, the therapeutic index of GI will equal 1 to 1. Not hard. That's good, not great. So that's one measure. The parallel measure means the same darn thing. The safety margin. So rather than doing a ratio, and we do not, we take that LD50 and subtract the ED50, and that equals your safety margin. So we'll use the same numbers. 100 minus 10 equals 90. It's an absolute value, in other words, it's always got the positive number. That thing, absolute value is another dose. Well, and that really is the wiggle room you have when you decide that. The therapeutic index and the safety margin kind of says, well, when we're using an agent, what happens if someone unintentionally or intentionally takes an overdose? Okay, how much room do I have? And as physicians, as nurses, you want wiggle room, because I mean, we all make errors, and particularly when you start dealing with some very medicines of people who are potentially suicidal. Not that antibiotics would fall into that category, just stick to your stomach for the most part. What'll happen is they're inclined, if they're unhappy with the way life is going, they'll swallow a whole bottle full and wash down with a bottle of vodka in an effort to end it all. And that's the reality of things that happen. So it's very apropos when you're talking about psychiatric medicine, sedative, hypnotic, sleeping pills, and stuff like that. Big trouble. But those are the numbers. Selective toxicity more harmful to the microbial host. Therapeutics index and the safety margin are saying the same thing. We typically talk about therapeutic index as a term. We use that more than safety margin, though effectively they're connoting the same thing. I know. I don't know if we get a chance to use connoting in a sentence. It's all right. When I was in 6th grade, we had, what was her name? Mrs. Ross. Okay. You should remember all your grade school teachers by name. Most of us do. Okay. She had a vocabulary builder. I love that. It was always an effort. So, what did I say? Therapeutic index integrated with a high. High is preferable. We'll talk about sort of the historical aspect in a bit, about really one of the most significant. If you wanted to look at the big things that changed the world vis-a-vis medicine, germ theory and Pasteur and all that, and Koch and all the stuff he did in the lab, that's a big player. Those historical figures I talked to you about, Jenner with the smallpox and really the first immunization. Okay, big players. Antibiotic X-rays, big players. Antibiotics. Okay. They've been around. Understand, but people didn't know what they were. So the ability to have medications that could be used to treat, there was really no way to treat infection. None. I mean, sometimes they did it inadvertently, and they put things that had mold or bacteria, and they were basically, as a product, producing something that was technically antimicrobial or antibacterial inadvertently. Okay, and it was found. But really, the discovery of what they were, I think the identification is probably a better word than discovery, but you could use them interchangeably in this. The discovery and their implementation, being able to refine them, being able to tinker with them in the lab, big deal. And most of the ones that you and I are familiar with, whether you're going to see cephalexin or whether you're going to say zithromycin, which is the Z-Pak, or cephalexin, which is Keflex. Ones that use ampicillin, amoxicillin, whatever you want. And we cover all of those in this particular chapter. They have a very famous name, again, to remember. They're called semi-synthetic antibiotics. All that means is we've taken the parent compound, which is produced naturally, and tinkered with it in the laboratory. We semi-made it. I mean, it was there to start. We've just tinkered with it. We've added a side group. We've added a substitution. We've done something to make it last longer, to be more effective, etc., etc. And very often to resist, inevitably, the mutations that have occurred in the bacteria we're trying to attack. So, and this is to reduce the incidence of a lot, but they will not eradicate. I'll buy that. This is a biggie. This is one of my main focuses of this whole micro course. We are running out of antibiotics at work. We blew it. People forgot the most important thing to understand about bacteria. They're alive. And living things have defenses against chemical warfare. In a word, they mutate. It's Darwin 101, descent with modification. Okay, bacteria, the ones that survive antibiotics, do so because they were genetically different for whatever reason, even spontaneous mutations or induced mutations. Okay, something occurred to them that made them able to survive this onslaught of chemical attack, and they were most likely to replicate. Okay, so they were the ones that were most likely to survive. We make more of them, and over time, that became the prevalent species. I'll say it. This is a starting point. We'll say it a couple of times. When they discovered penicillin, when they identified it, 90 to 95% of all Staphylococcus aureus, public enemy number one by any measure, okay, the most common source of bacterial infections. That was number one. 90 to 95% of them were susceptible to penicillin. We have evolved that twice. First into a strain that was resistant to penicillin, and then, we've changed penicillin, this is part of this chapter, and we made something called methicillin to attack the way it resisted by forming an enzyme to attack that enzyme. And guess what? It evolved again and begat MRSA, methicillin-resistant Staphylococcus aureus. All this in the span of roughly 75, 80 years. It's roughly 1940, 1941 when the actual production of penicillin began. 1941, 84 years ago. Wow. I mean, wow. So we didn't understand that when you attack living things with chemical warfare, they mutate. And if the mutations are such that they're more likely to survive, guess what's going to become the predominant species? So that's kind of what happened. So we're running into what we call superbugs. Thankfully, they've not come our way yet, but there's so much worry about this that's coming on. So administer a drug to an infected person that destroys the infective agent without harming the host cells. That's the panacea. The reality is there's very few of these that exist, okay, where it's the perfect agent. You want to know what the best agent of them all is? The first one, penicillin. The big problem with penicillin, allergies. It comes from mold. And we overused it and sensitized people to it. So more people are the three saddest words. I say it again and again, that any physician, any clinician can hear: allergic to penicillin. You took the best weapons away. Because it doesn't just stop the bacteria from growing, it kills them. And we want them dead, morphed, dead, sleeping with the fishes, deceased, 6 feet under, taking the dirt. All those wonderful cliches I like to use. Double tap. Done. The reality is that was the best of the antibiotics. It had its limitations, as you will find out. It's wonderful for the most part against gram-positives. It's lousy for the most part against gram-negatives. So it's interesting how that, because effectively, we talked about this very first week of lecture. What does it target? Peptidoglycan. And what don't we have any of in our bodies? Peptidoglycan. It's got a target that will only hurt the bacteria, not us. Big problem. So administer it, able to reach infections anywhere in the body. As part of that's in the lab. We'll talk about those. Be absolutely toxic and absolutely non-toxic. Again, that's a panacea. So despite them being allergies, they can still hurt somebody or kill somebody. Okay. Remain active in the body as long as needed and be safely and easily broken down and excreted. All of those are things that you have to deal with in the process. They're all antibiotics are not created equal. That's why there's so many choices. Okay. So ideal. And that's what I mean. It's ideals. Toxic to the microbe, but non-toxic to the host. The big word, kill it. Again, if we kill it, we know it's dead. On the other hand, and I mean, I realize viruses, we can't really classify that, but I mean, take it in sort of the generic way of looking at it. We're looking for maximum efficiency. The problem with anything that is static implies slowing the growth cycle or impeding the growth cycle in such a way that your immune system can take over and eliminate the problem. That's what happens when you're allergic to penicillin. You take away most of the weapons that are cidal and they have to be static. And you're just, again, it's always fraught with problems. It's always a risk. First thing you learn clinically when as a physician on the floor, when you're going, oh, here we go, allergic to penicillin. That's why a lot of times you just don't say, well, I'm allergic to penicillin, and it wipes them all out. A lot of times you research and figure out, is that really the case? Okay. There's a lot of times someone said, oh, just tell me you're allergic to penicillin, it could kill you. You could have an anaphylactic shock. It's like, when someone tells you they're allergic to something, it's not enough. Do you have any allergies to any medicines? You're taking a history. Penicillin, this, that, okay, little green apples, strawberries, whatever you want to write. The appropriate thing is not what next. Does anybody in your family have this or that? No. Don't just do your job. Do your job well, thoroughly. How do you do your job thoroughly? Really, you're allergic to penicillin? My mom is. What does it do to you? If they say it gives me a terrible headache or a stomach ache, that's not an allergy. That's a side effect. They're talking rash, can't breathe, swell up like a balloon, have hives all over my body. That's an allergy. Okay. People just tell you if they didn't like the way it made them feel, and a lot of times their major side effects are all gastrointestinal. Headache, nausea, vomiting. Don't like the way it made me feel. I was all messed up. I couldn't work that day. I'm living in the bathroom, whatever. A lot of times, if that's the case, they will instinctively slam down. Just tell me you're allergic. They won't give it to you again. Don't fall for that. It's the same thing with vaccinations. Well, when was your last tetanus shot? Oh, 2 years ago. Oh, you did your job. You asked when their last tetanus shot was. Patient states they are tetanus current. Oh, really? Where'd you get the shot? Did we give it to you? Were you here in the ER? What happened? Find out for sure. Okay. How many times do I have to tell you that wonderful TV show that ran for 7 years, House? What was the premise of that show? Patients lie. They lie all the time. That is the premise, number one. That whole don't assume, you know what assuming does? Okay. We like to have them work even if they're well diluted. In other words, have a little bit work well. We want them to last for a long time. We don't want them to make resistant. It assists the other activities of our host defenses. Yeah, if we found that, we make $1 zillion. Remains active, not always, ready to be delivered. You're going to see a lot of problems. They don't always, it's a big problem when we can't make a pill. Okay, because then we have to do it by injection, and people don't like to stick themselves. It does not drift your host's health by causing allergies or predisposing the host to other infections. Good luck, trooper. That's the idea of a panacea. It's something that it's the perfect agent. We just, like anything else, just like when I was telling you about various agents we use for sterilization, for disinfection. If we all use it, if the perfect one exists, it just doesn't. Be nice if it does. So, prevention. That's what prophylaxis means. Do we use prophylactic antibiotics? Here's another one that just drives you crazy. You do a clean surgical procedure. You're going to have this. You're going to be taking care of a patient, and you'll be working in recovery. You'll be working in outpatient. They just had their knee scoped. Maybe they repaired a medial meniscal tear. I mean, it takes minutes to do that. It's a totally clean procedure. Well, here the doctor's sending you home. You're going to have 3 days worth of pain pills and blah, 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 and all that type of thing. If you get the pain pills, you don't always do that. What about antibiotics? You don't need them. They're contraindicated. People wonder why. Well, I didn't get any before. It's a clean procedure. But when you're constantly giving people antibiotics, you're basically telling the bacteria, here's an opportunity to get used to this stuff. When do we use prophylactic antibiotics? When someone has a very high risk of having an infection, like a diabetic, someone with immunological problems, and maybe you ought to think twice about operating. If you're using multiple surgical incisions, this is all, I'm not going to ask you a zillion questions, but this is for your information. More than one incision, that increases the risk. A previous history of infection in and around that site, or you're putting something different in there, like metallic hardware or an implant. That's when I use them. And interestingly, we don't give them long haul because it bothers them. You do what we call perioperative, around the time of the operation. We typically, if you're doing it in an outpatient area, if you're doing it in the office orally, it's different. But basically what you do, you start an IV with it immediately before, during, and after. They probably get 3 doses, so it kind of sits there. Got it? So understand, that's the first thing. And that's a question, believe me, if you're going into nursing or a clinical field, someone's going to ask you, why didn't I get antibiotics? I always get antibiotics. Don't want, because we've overused them. That's why you always got antibiotics. It's not nice to say to the doctor because it's stupid. I was going to say an effing idiot, but I don't want to say that. Okay, moving on. So when we talk chemotherapy, has nothing to do with cancer, unless it says cancer chemotherapy. Chemotherapy using chemicals for a therapeutic purpose. Antibiotics are chemicals, antivirals, antimicrobials. The all-inclusive term for all of the above. Antibiotics, antivirals, antifungals, all things in this chapter. Antibiotics. Super important definition that you do. I'm dying here. So do antibiotic. Substances produced by the natural metabolic processes of some microorganisms that can inhibit or destroy other microorganisms. It's got to come from another. It's competitive inhibition. If you want to get rid of a bacteria or a microbe, it's great if it comes from one of them, because they're struggling. What happens is they're struggling, they're fighting for their existence. So they make things that'll favor their ability to live. That's kind of how it works. Oh, someone's going to come to attack us. We're going to build a fort. We're going to create walls. We're going to have whatever. Think historically. We'll have better spears. We'll have bows and arrows. Okay. That's from a microbial world. That's what they do. So we typically see them from a couple of different types of bacteria, a couple of types of different mold. They are naturally occurring. So, and generally, it's targeting bacteria, not other types of microbes. There are no antiviral antibiotics. There are no antifungal antibiotics. Antifungal antibiotics, I shouldn't say that. But there's no antivirals. And I think that would be the easiest. The other ones, I'd have to look at the categories. This is why I said semi-synthetics. They're chemically modified in the lab after originally being naturally occurring. So again, antivirals, they're all from the lab. They're purely synthetic. We have a lot of agents we use for bacteria that are made in the lab. Nothing wrong with that if they work. And the idea of their spectrum of activity. Nowadays, the modern definition, broad and limited, or narrow and broad are the terms. Typically, it means, does it target both gram positives and gram negatives? That's considered broad. Okay. Narrow indicates it's basically effective against either gram positives or gram negatives. Broad isn't better. Because a lot of times, take tetracycline. You know somebody who takes fibromycin or minicin. We use low-dose therapy for acne. It targets both gram positives and gram negatives. Not terribly effective, but useful for certain problems. So the fact that, and for years, the mistake that was made and what led to all of the, not all, but most of the problems that we have today, we decided, oh, somebody came in and we hit them with a big bomb. They came in with a staphylococcal infection that was relatively easy to treat, and we used the strongest antibiotic we could find. Well, I want my patient to get better. That's fine. If you don't at the start, if you use something broad spectrum until you know what's going on. Okay, then, and this is what I did. Not because I'm brilliant, because we were taught to do this, because we start to figure it out. Start them on a broad spectrum agent, like Keflex. Sometimes it's the best choice. And I would tell them, we're going to do a culture and sensitivity. It takes at least 48 hours. I'm giving you enough for whatever, 3 to 5 days. We will call you. If we say, go ahead, get it renewed, get it renewed. If not, please understand that we may have to change the antibiotics. So nobody likes surprises, particularly patients who are sick. So understand, well, the doctor made a mistake. They changed the antibiotics because they had to sometimes. The appropriate approach then is to narrow it down once you identify it. You may have a good choice and it's very specifically targeted. That's the way they work. So made from that bacteria or fungi, basically. It's mold or yeast. They inhibit the growth or kill of competing microbes in their habitats, how they work. And by and large, we get them from Penicillium or Cephalosporin. Those are the molds. If you're cultivating a little mold in lab, that's what you found. White bread mold is Penicillium species. These are extraordinarily common. That's why people were inadvertently using these, okay, without knowing what they were. Oh, this mold, I mean, if you go back and look historically, they were herbalists. They used herbs, they used infusions, they used potions. They thought they were magic. No, they weren't. Okay, there are things we use today. We just didn't know how they all work together. And they'd slap things on them that actually work. And the bacteria, bacillus, you work with in the lab, B sub in the laboratory, makes something that is in triple antibiotic ointment. Bacitracin, how it gets its name, BAC. And streptomyces gave us streptomycin, but it also gave us erythromycin, okay, which is the parent of the Z-Pak, it's azithromycin. We'll get to all those as well. But this is what we have to do. This goes back to Coke. We've got to figure out what it is. We've got to grow it in pure culture. And then we have to test it. That's what you're doing in lab. And it's called culture and sensitivity. We have to identify what it is. And sensitivity means what can impact it in the sense of destroy it. And that's what you're doing in the lab. And yeah, we're not done yet. Oh, I found this great antibiotic. It works really wonderfully. Good news. Bad news, they're allergic to it. Bad news, they can't tolerate because they have some underlying medical condition. Bad news, try this one. Insurance won't pay for it. Try to use something else. Because they can't afford, $1,000 a pill. There's a lot of those that go around. We probably didn't tell you this. When I started practice in Oil City in 1979, I had one of those ladies who weighed less than she was old. Bertie Miller. Described her perfectly. I mean, I treated, if she was 85, she didn't weigh 85 pounds. And I gave her a prescription for an infection. She looked at me, she said, I can't afford it. My first wife and I were shopping at a little grocery store, a little IGA, Independent Grocer Association, a little small town. Okay, she's shopping there. I know she didn't have a cat. Guess what she was filling her shopping cart with? Cat food. What does that tell you? My first wife, RN, BSN, wonderful person, foolish choices in men. me. She went around and she bought a whole bunch of stuff, and as the lady was walking out, she threw in her shopping cart. We're paying for this. God bless her. My wife does that now. We'll see somebody at the thrift store who's looking longingly with a little kid. She take a 20 and put it in their pocket. It's good. It's a good thing to do. Nevertheless, be aware that they're not always people. The fact that you're giving it to them doesn't mean they're going to get it or they're going to take it. There's a lot that goes on. This is something you see. Clinical experience, a great teacher. So we have to identify it, early identification and treatment, optimally before you use, but you don't have a choice, because if you attack it too late, then there are vast numbers. It's hard to overcome. And this is what we would do. The rapid method, we would take a sample of the pus, not the pus, the long term, of the stuff under the pus. We'll get to that. Okay, so mucus, sputum, stool, urine, all of those are used. I would have a wound, and that's why I corrected myself right away. Pus has got dead stuff in it. It's not a reliable means. It'll have bacteria, but it's like dead bacteria. You really can't grow it very effectively. You take it away, you get the basin size of the wound, you take a sample, just what we do in the lab. Okay, we do a gram stain. Then we take another sample, and this is what you're going to be doing in the lab this week. You put it on a specific plate, and you put little antibiotic discs on it, and you let it grow for a couple of days, and you start looking at it. You're going to see it in a second. So we do what's called empiric idea. If I see something you've all seen these gram-positive cocci and clusters on a stat, which means an immediate gram stain, which we used to do, or I'd send it up to the hospital right away. Okay? And even tell the patient, because we didn't necessarily, I wanted to be sure, I'll send it up to the hospital right away, because it's a small town, and they call me right away, and I will call in a prescription for you. So we do a stat gram stain, or we do one in the office, and if I saw gram-positive cocci and clusters, it's Staphylococcus until proven otherwise. And you start them on something appropriate. Are they allergic to penicillin or not? And then you change. And yeah, there's difference. Sometimes we have to look epidemiologically at what's going around, et cetera, et cetera. So, following Staphylococcus, Neisseria gonorrhea, we don't see as much as we used to. Remember, I commented on this a little bit. This is an interesting strain of Streptococcus called Enterococcus faecalis. All sorts of intestinal bacilli, E. coli and friends. E. coli, Proteus, Klebsiella, all wonderful names you'll become familiar with in the lab. They're like old friends. Okay. So we have to do all of these things, and sometimes things just don't work it, so you really have to do this. In general, these tests involve a pure culture of the microbe to several different organisms and watching their effects. So this is what you're doing in lab. It's called the Kirby-Bauer technique. In my lab, we'll go over this again. I'm sure Dr. Dress will do this again. We use a specific agar you're going to learn about. It's called Mueller Hint. I don't have to go into it now. It's a complex media, which means it grows a lot of stuff. Okay, we want something that stuff will grow easily in. It's got a lot of goodies in it. Okay, and really, you typically use that media unless you expect it's one of these that's hard to grow, like gonorrhea. Because you'll learn when we get to this, gonorrhea is gram-negative diplococci, and when you see that in a sample from the urinary tract, either any type of discharge genitally, okay, and you see that on a slide, I mean, it's just not good. It doesn't like to grow at all. You have to use special media. Interesting, it's got a great name. Chocolate agar. Another name is Theramorn. I think it's a criminal waste to put chocolate in an agar. It's not chocolate. So what wouldn't like growing in chocolate? I'm a chocoholic. That was another thing that why our marriage didn't last. She didn't like chocolate. You thought I was crazy. No, she was allergic to it. My wife and I are both confirmed chocoholics. food mode. Just think of something. So we take these tiny discs. The discs are, pardon the term, impregnated. They're little, they look like just little paper discs. They're porous, and they have a set amount of antibiotic, and they are labeled, so you don't even have to label them. Okay, and you put them on the plate so they don't overlap, and they create a zone around them called a zone of inhibition, which means in here, and you're going to see it, and we measure it, and there's a standard for this. Voila! Let me go there. That's the test you're doing. That's Kirby Biol. So basically, plate this out. You create what's called a lawn of bacteria, and we look for what are called zones of, like, obviously that didn't work. It's not bigger is better. Understand that. I'll reiterate this to my lab. Bigger is not better. This is what's called a qualitative test. Qualitative means did it work or not. So we can only tell three things from that test. Did it work or not? Okay, and the way we classify it is susceptible. And let's say, for argument's sake, we take one that's a big zone like that, and we measure it across, and we measure the diameter, and I'll go back and show you the chart. And if it's in the right area, we can classify as susceptible, meaning we want to use that. This one's obviously resistant, didn't work at all. And then there's an I in the middle called indeterminate. We don't know. It's in a bad zone. The fact that there is a zone doesn't mean it works. It may be resistant. Some of these need to have a big zone, some a little zone. Why do we want to know all of those? Because what if all the ones that appear to work susceptible, there's allergies, or if the patient would not be able to tolerate it for whatever reason? Sometimes you have to use the indeterminate one. Take your best shot. There's all sort of them. So intermediate or indeterminate are the terms that are used. I don't want to confuse you. But here, I'll show you. Back it up and see. So you'll use erythromycin. That's kind of the Z-Pack. So it's got to be greater than 18 or less than 13. If it falls in between them, we don't know. And it's not, every bacteria are not created equal. These are for Staphylococcus aureus. Okay? I'm telling you right now, gentamicin, kanamycin, neomycin don't work. They just don't work on it. They're for gram negatives. Penicillin, you need a whole lot, you need a big ass zone for penicillin. Just giving you an idea. And you see all of these things are ways that when you evaluate that, that's what you come up with. And every time from a laboratory, these are all published. Wherever you buy the discs, and we're going to use the discs in lab, and you're going to use the discs in lab, whether it's myself or Dr. Dress, there's a master list that comes with them with the antibiotics. And it's easily lookupable. It's not a problem whatsoever. And there are other alternatives that you can use for that. Typically, when we make this, we have a sample that has grown in a test tube. And you might remember me, maybe I didn't. The way we look at that is how turbid it is. In other words, how much is growing in the test tube. Remember, we take it for a spin. You probably did this in lab, and you look at it to see how cloudy it is. We standardize the cloudiness. Okay, if you did not know, and this is lab stuff you don't have to know for lecture, and we measure it in a spectrophotometer. In other words, to see how much light goes through. And that way we can determine this uniform sample to something called MIC. And when you get them in the hospital, that basically tells you the dosage. Oh, not only does this antibiotic work, but you're going to need to use, patient's going to have to get a gram every 8 hours intravenously for it to work. Patient's going to have to get 750 milligrams orally. And another thing, patients drive them nuts. Why did you give me such a weak antibiotic? I have to take a gram a day. My girlfriend got an antibiotic. She only has to take 100 milligrams once a day. Nobody cares. It has to do with a concept called potency. Medicines are not created equal. You know, about the strongest painkiller that most people utilize pill form is Percocet. 5 milligrams of oxycodone Tylenol, you take a gram, 500 milligrams times 2, BID Q48, Q8, 6 to 8 hours. That's it. So stop that nonsense with, you got to tell them that. Listen, they're not all created. Some are just, we call that potency. People who use hallucinogenic drugs like LSD, okay, is in micrograms. Like that, not that I have a tremendous amount of knowledge of this, but we used to see how many mics were in there. Those are called micrograms. It was a different age. Statute of limitations is expired. Just say. Like I said, where are you going on spring break? You didn't have to go anywhere. You could be anywhere you want. Just put up a poster. Album covers. Great. Stop it. Allie, I cannot help it if you're innocent. Just saying. Just look at me like, I can't believe it. Yes, we all got into trouble in college. So, and all of this is, a lot of this is lab stuff, but I wanted to give it to you in preparation without giving you the heavy stuff. I wanted to do some definitions, and I wanted to give you this information as ongoing into labs, why we're doing what we do. And I felt it tied in nicely. And one of the things, God bless Dr. Robbins, most of the time lecture ties in with lab nowadays. I mean, he's got it down, and I'm working with him, and we're trying to do that. It was a big problem years ago. So in vitro activity, it doesn't mean the same. It's a great point. The fact that it works in the lab, that's a freaking test tube. Well, in vitro, which means in a test tube in the laboratory, versus in vivo, living thing. The fact that it works in the lab, how many times will you hear people, that antibiotic didn't work? The lab said it was going to work, it didn't work. It just doesn't happen that way. There's a wonderful medication called ciprofloxacin. Cipro. Been around for about 40 years. I was around when they first, not discovered is the wrong term, when they first started to utilize it and market it. The pharmaceutical company, I don't recall ever produced it initially, came around. It was the best thing since sliced bread. It'll work if you're allergic to penicillin. It's bactericidal. Okay, it'll work on staph, it'll work on strep, it'll work on gram negatives. We started using it like crazy. Okay? We sit around at medical conferences. What do doctors talk about other than their bank account, where they're going on vacation, and stuff like that? Are you using Cipro? I said, yeah, I use it. She said, have you tried it on staph and strep? I said, yeah, I tried it once, it doesn't work. The lab stuff says it works. It doesn't work. Clinically, it does not work. Okay? We learned that right away. Its best efficacy is against gram-negative rods, like E. coli and those things. It works great against them. E. coli, Salmonella, Shigella, Vibrio, pick one. It works against all of those agents. It does not, even though it says it will take care of Staphylococcus aureus, even if it's methicillin resistant, in the laboratory, one of those plates, it doesn't work in real life. It took doctors about a year or two to notice that. Once they noticed it, nobody used it anymore. The drug company didn't necessarily correct it initially, but the doctors stopped using it. And when they'd come in, the pharmaceutical sales rep would come in and go, you're not writing for it. It doesn't work. So understand that everything is a lab test. What happens in the laboratory doesn't necessarily work in the human body. It's just like that. There's so many other factors. And this one happened to be universal. It wasn't selected individuals. So what's the failure due to? Inability of the drug to get to the right place. Things don't cross the blood-brain barrier. You need high concentrations to typically get into the kidney for some of these things. Things that work on a urinary tract infection don't necessarily work on a kidney infection. It's different. For instance, so you've got, sometimes you need heavier duty stuff to get where it's supposed to. Okay? In biofilms, which we told you might remember, They form those colonies like dental tartar. It is tough to penetrate a biofilm. I have someone in my prayers today who I'm very, very fond of. They're having to redo her artificial hip. She had so many problems with it. She's probably in surgery now. And one of the big problems with it was an infection. One of the big problems with implanted orthopedic devices, they attract biofilms. If there's an infection, it's very, very difficult to penetrate. I'll talk about it when we look at specific antibiotics. So we have to find ones that can penetrate this. They don't always do that. For instance, okay, my best friend's wife who happens to be undergoing this procedure as we speak down in Miami. Okay, so all of that, the biofilm, resistance in the infection that did not make it into the sample. When you test, it's random. An infection caused by more than one agent. That's another big thing. Watch out. Diabetics get polymicrobial infections, meaning more than one. So and sometimes you have to give them multiple antibiotics, multiple culprits. Yeah, here's this one. Yeah, if you're not administering it, and we don't keep people in the hospital because of the money aspect of it. We get somebody in with an infection like that, we give them 2 or 3 days. The minute the numbers start to improve, you have to discharge them. Keep them in overnight, maybe 2 days. There's no guarantee, unless someone is administering at home who's reliable, that they're taking this stuff or even purchased it. And so the whole idea, therapeutic dose, the smaller the ratio, the biggest problem. So the illustration, just by chance, was 10, was safer, not great. This is bad. Years ago, we used to use alcohol as a general anesthetic. It's like in the movies, we would have a lot of alcohol because we didn't have general anesthetics. Alcohol is a bad choice because it causes bleeding excessively and inhibits certain things. The biggest single problem is the lethal dose and the effective dose are right next to each other. I mean, these horrible things with these fraternity things that went on for years where somebody dies because of, it happened when I was 50 years ago. When I was a student in a big fraternity school. Every year you see one of these things goes on. That's because of that very limited therapeutic index. Okay. So that's safety margin. And so this is all kind of part of it. We'll stop it here. And I hope you got something out of this introductory stuff. We'll carry it on Friday, and we'll be here. I'll get here, my usual. I'll get here relatively early if you're into coming in early to get this test started. Thank you.